Okay, I think we're probably about ready to get started. Welcome everyone. I'm so excited to have you all here. This is a very exciting program and we're just so glad to have all of you here, and thank you for applying. My name is Jessica Windhouse. I'm the project manager of the Early Psychosis Training and Technical Assistance Center. So if you're not sure why you're here because your county applied and received funding through DHS's federal grants branch for your first episode psychosis program through the SAMHSA Mental Health Block Grant Supplemental Coronavirus Response and Relief Supplemental Appropriations Act and/or American Rescue Plan Act funding streams. Whew, that's a long name for this funding stream. So DHCS has partnered with the EPI-CAL Early Psychosis Training and Technical Assistance Center, and that is us, and to support your clinics. So today we're going to be introducing our program to you and our team and just sort of orient you to who we are, what we do, and next steps from here. I do want to just let you all know that a copy of the slides from this presentation will be emailed to you afterwards, in addition to some other items that I'll go through later. And any folks who want to review this meeting later, or if you have colleagues who weren't able to attend today, this meeting will be recorded and I will distribute the link to the recording. All right. So I just want to welcome you all once again. Very excited to have you all here. So we are the Early Psychosis Training and Technical Assistance Center, and we are part of EPI-CAL, which is a statewide program. So just a sort of sidebar, in addition to these slides, we'll also send a welcome packet that's going to be a lot more detailed than a lot of these slides. We're going to go into a lot more detail in there. So I do want to encourage you, once I've emailed that out, to review it at your leisure, and that'll have more information in there. But before I talk about our program, I would like to go ahead and introduce our team. So this program, again, the TTA, is presented by UC Davis, but it's also a collaboration with our colleagues at UC San Francisco and Stanford University. And also, I just want to mention once again that I will be your main point of contact going forward. So if you have any questions in general about the program, or you're not sure who to ask, you can ask me. My email address is right there, and we're probably already in touch since you're here. You can go ahead and reach out to me and I will try to get you where you need to go. All right, so we have some folks from our team here today. So we have Dr. Tara Neendem, who is the program director. Tara, do you want to introduce yourself?
Good morning, everyone. So excited to see all of you here. So many familiar faces and names. It's really wonderful to be able to start to create a community of early psychosis care providers. I know a lot of you on this call are quite experienced in this area, so we're excited to benefit from your expertise. And then we got some folks who are joining this movement. And so we're really proud to be able to support you as you all work to serve your communities in this new and exciting way. So as Jess said, please reach out to us if you have any questions. As I like to say, there's no silly or stupid questions. If you've got a question, please ask. And if there's any concerns, please don't hesitate to email me as well. We want to make sure you all feel supported and that your questions are answered. So thank you all for coming today. It'll be lovely to work with you.
Awesome. Thank you, Tara. All right, I also want to introduce, it looks like Dr. Laura Tully is on the call as well. They're the assistant director. Tully, do you want to introduce yourself?
Yes, thank you, Jess. Hi, everybody. I'm Dr. Laura Tully. I prefer to be called Tully or Dr. Tully if we're working with clients. I mostly on this, I know some of the folks on the call, it's good to see you, but there's lots of new faces, so thank you for joining. Mostly my job on this project is to work with Jess and our leadership team to do the overarching, what we're calling learning management team. That means all of the logistics of releasing the materials, the training materials to you, making sure that they're in an accessible form, making sure that you have access to what you need in order to learn the things that you want to learn and support your team in learning the things that they want to learn. So really, I would direct you to give us feedback on our feedback surveys around the training content that we're releasing, and to send any suggestions or questions to Jess if there's things that you think we should be doing that we're not doing, additional content that you're interested in learning about, and then we'll integrate that into our learning management systems. So welcome everybody, and it's good to see you. Happy Friday.
Awesome, thank you, Tully. And yeah, we'll be touching base more on training later as well. So I'll be happy to provide some more clarification about that. So those are sort of the key personnel over at UC Davis. We also have at UCSF, we have Dr. Rachel Lowy. I don't believe she's on this call today, but she's the site PI over at UCSF, professor of psychiatry and behavioral sciences. And she also serves on the leadership team, and she works as the assessment team lead as well. So I'm sure you'll be speaking to her throughout the course of the project. We also have Dr. Kate Hardy, who is the site PI over at Stanford, and she is also our CBT team lead, and also is wonderful and talented, and I'm sure you'll also be meeting her and touching base with her frequently. So those are some of our key personnel. We do have a wonderful and robust team of very cool people who will be happy to help you and who you'll be communicating with more. So I want to be sure that I mention them, but these are some of the key personnel that you'll be working with. Okay, so I just wanted to touch base on our sponsors really quickly. So obviously we have the California Department of Healthcare Services, DHCS. We have SAMHSA, also another one of our grants whose grantees we work with as part of this program over at the MHBG. We have the National Institute of Mental Health and OneMind. So those are some of these sponsors on this program. And we just want to obviously give a big thank you and shout out to them for making this program possible. We obviously greatly appreciate it. And we hope to do really amazing things together in partnership with them and with you. All right. And I do also want to reiterate that we have a lot of details on these different programs in our welcome packet. So if you want to read more about them, that's where you can find that. Okay, so a little bit about us. So we were created thanks to AB 1315, California legislation, and the MHS-OAC to expand the provision of high quality evidence-based early psychosis and mood disorder detection and intervention in California. And recently we have teamed up with DHCS and SAMHSA to expand to more counties in California, which is why you're here. So again, we're very excited. We'll talk more about other programs connected to ours in a moment, but also I do want to touch base on our mission as a program. So the TTA was developed by UC Davis in collaboration with UC San Francisco and Stanford. We provide training and technical assistance to support implementation and sustainability of early psychosis programs across California. Our goals are to support the provision of high quality early psychosis care to all Californians and to promote recovery and better outcomes through a learning healthcare network approach. All right, that's a little bit about our mission. So we'll talk about some of the other programs connected to ours. So here we go. Let's dive in. So you've heard us mention EPI-CAL. So the TTA, which we've been talking about, is a component of EPI-CAL, aka the California Early Psychosis Intervention Program. So EPI-CAL receives funding from several different counties through MHS-OAC, OneMind, and IMH. And it's comprised of two different initiatives, the Learning Healthcare Network and the TTA. So obviously, again, this is the TTA, and we'll talk more about the Learning Healthcare Network in a moment. It's sort of a sister program. So we'll talk more about that in a moment and help you conceptualize that. So these are the primary goals of EPI-CAL: to understand the current status of existing early psychosis programs across California, which practices among which programs are promoting client recovery, the needs and priorities of clients, families, and communities, and how data can influence collaborative care decisions in real time. So that's a little bit about us and our funding. All right, so this is you, mental health block grant grantees. So the Community Mental Health Services Block Grant or Mental Health Block Grant program aims to support grantees in carrying out plans for providing comprehensive community health services. This is the name of the grant that we've been referring to, the grant SAMHSA and DHCS provided to eligible counties to apply for funding to receive our training and technical assistance services for your early psychosis programs serving clients with recent onset psychosis. So we will be referring to you as MHBG or mental health block grant, or you might hear us refer to you as DHCS within our program. So these are some of the counties who are here on this call. And once again, we're very excited to have you all here. All right, I know I'm going through a lot of stuff, so I do want to just mention that we will have time for questions. So I appreciate your patience there. But if you have a burning question, please feel free to raise a hand, and anyone else on the call from our team, if there's a question that I don't see in the chat or if someone has raised a hand, please feel free to stop me. All right, so this is the LHCN. So I was mentioning this a moment ago. This is sort of a sister program. So we actually have Dr. Valerie Treon on the call. Valerie, do you want to touch base on the LHCN?
Sure. Thank you for the introduction. So as Jess was mentioning, EPI-CAL is kind of this overarching program that includes the TTA and the Learning Healthcare Network, the LHCN, and one of the primary goals of EPI-CAL is to improve the quality of services and measure the impact of treatment in early psychosis programs. So in order to measure the impact of treatment in early psychosis programs, we have to have outcomes data collection. And so the goal of the LHCN is to standardize practice and support knowledge sharing through outcomes data collection. And so we are harmonizing outcomes data collection across participating early psychosis programs in the state, and also sharing that data back with the programs and clients and families who participate using a novel technology that we developed that we're calling Beehive. And this will bring that outcomes data that is collected back to the clients and the families that are using it, as well as their providers, as well as standardize the data that is collected. So we'll get into more details about this, but you all will be encouraged to participate in the Learning Healthcare Network and this outcomes data collection. So if you have any questions, please don't hesitate to reach out to me. My contact information is down there at the bottom. Thank you.
Awesome. Thank you so much, Valerie. All right. Okay, so don't panic, but here's a conceptualization of all of the different agencies under the umbrella of EPI-CAL up here. And this is where we are. So we've been talking about the TTA, right? The Early Psychosis Training and Technical Assistance Center. We're part of EPI-CAL. This is the LHCN, which we've been talking about. And there's also EPI-CAL R01. So these are some of the other programs that are part of EPI-CAL. And as Valerie was just mentioning, these two sort of sister programs work with each other quite a bit. And then I wanted to focus here because this is relevant to you. So some of you on the call are already EPI Plus grantees, and it's great to see you all. So this is a separate grant that receives very similar training and technical assistance services from us. And then once again, this is you. You are here. This is you. And these are, again, some of the counties who are here on this call. So we hope this sort of helps conceptualize this flow. Some of the feedback that we receive most often is that, you know, the funding sources, the agencies, the programs can be sort of confusing. So really hoping that this helps conceptualize. EPI Plus and MHBG are both part of the TTA, and the TTA is part of EPI-CAL. So hoping that helps. Again, feel free to refer to the welcome packet that I'll send out at the end of this training to sort of wrap your head around this. Okay. All right, so we're going to talk a little bit about CSC, which is the Coordinated Specialty Care Model. So we don't have enough time to discuss the CSC in depth during this presentation, but it is central to what we do here at the TTA and at EPI-CAL in general. So we're going to be sending you a video that has an overview of CSC, and also your welcome packet does have more information. And again, we'll be talking about CSC quite a bit. I'm sorry, this says EPI Plus. And that's true, EPI Plus grantees are expected to do this, but mental health block grant grantees are expected to provide services consistent with the Coordinated Specialty Care Model, which is a team-based program providing an array of evidence-based interventions for psychosis. So this is a little bit of the conceptualization of CSC that was originally tested by RAISE. We have a little bit of a different model that we implement here at the TTA, and again, that information can be found in your welcome packet. All right. So what actually is the TTA and what do we do? We're going to talk about that in a moment. So here's a little bit about what we do. So and we'll talk more about this in a moment, but we will develop a TTA plan based on an initial site evaluation to bring your early psychosis program to fidelity and improve client outcomes. And we can make changes and tweaks along the way. We'll provide live and on-demand / online trainings on components of CSE, including assessment, training, medication management, outreach, new and emerging evidence-based practices, and other CSE model components. We'll provide ongoing consultations with your team to address and troubleshoot obstacles and discuss progress towards the TTA goals according to your program's TTA plan. And we'll generally assist with sustainability and development of your EP program. Excuse me. We will carry out fidelity assessments, which we'll talk about more in detail in a bit, in collaboration with your team to monitor progress towards fidelity and evaluate the impact of TTA activities. We provide a monthly newsletter with helpful tips, upcoming trainings, and more. We provide limited psychoeducational and outreach materials and threshold languages. We also convene an annual learning collaborative for early psychosis programs and encourage collaboration between early psychosis programs. And we share relevant early psychosis resources and opportunities. So that's a little bit about what we do. All right, so I'm going to talk now about what you do. I'm so sorry. Yes, I am seeing a direct message. Yes, Inyo County should be here. I'm so sorry they're not included on that list because we only yesterday received your narrative. So sorry, you are more than welcome to be here and we will have you added to that list. All right, so what you do as a grantee of this program, you're expected to obviously provide services to recent onset psychosis clients within your county. And we'll talk more about what exactly that means, recent onset psychosis. Attend trainings assigned to you by role at your clinic and track participation and progress. Attend quarterly consultations with our team. Work collaboratively towards increasing early psychosis program quality. Participate in fidelity assessments. And participate in data collection to aid in the tracking of progress towards fidelity amongst all EP programs in California. And again, the best way to do this is to join the Learning Healthcare Network. And we can talk about that more in detail later. All right. Okay, so obviously our acronym, the TTA, is an acronym. And the first part of that acronym is training. So I'm going to provide you with more information about our trainings soon, including a schedule and which trainings you can access. We have a lot of archived trainings for on-demand training. So as part of our program, we provide a suite of training modules designed to aid programs in developing or sustaining their early psychosis programs in accordance with the CSE model. So as a TTA member, you have access to these learning activities. Training is delivered via a mix of self-paced learning activities, assignments, low-stakes quizzes, webinars, recorded videos, and group discussions. All training materials are provided and should be completed on our learning management system, which is currently Canvas. Staff at your clinic will be assigned different trainings depending on their role within your clinic. So rather than it being one size fits all, different folks, different staff members at your clinic will be provided with different trainings that best suit their role. Our training manual is a comprehensive overview of these training offerings, and we can provide those to you at a later date, but that will be a helpful overview of all of the trainings that we have. Okay. So obviously the second part of our acronym is technical assistance. So as part of our program, we offer periodic Zoom consultations and provide specialized assistance to each EP program to help solve technical issues, provide program management guidance, and connect programs with resources needed to reach fidelity and improve client outcomes. So obviously not all subjects are going to be covered in trainings because, obviously there are challenges that we want to help you overcome. So here are some specific topics on which we'll provide consultation. Early psychosis program design and development, program initiation, scaling and modifications to meet need, management issues and supervision, workforce development and retention, targeting clinical and support staff, including peers, use of outcomes data to show impact of program investment, TTA training activities and progress, sustaining program fidelity, and all components of the CSE model. So that's the technical assistance that we provide in general and during our consultations. Okay, so we're almost in the home stretch before we have a little break for questions. So what is fidelity? We're going to talk about fidelity and fidelity measures. We've mentioned fidelity assessments a few times here. So fidelity is the degree to which an activity is delivered consistent to evidence-based practices. In the TTA, the fidelity assessments will measure how closely your program is delivering coordinated specialty care in accordance with evidence-based practices against a set of objective criteria. Grantee improvement on fidelity scores over time is the primary outcome metric for the TTA. So for participants in the mental health block grant, fidelity assessments will be conducted in a two-stage series. The first assessment will only include established programs identified during the initial review of your grant applications. And then the second set of assessments will include the previously assessed group, so the one I just mentioned in number 1, to evaluate changes in fidelity to the CSE model after training and technical assistance. And it will also involve a first evaluation of programs that were new or not established at the time of the initial assessment, so the one I mentioned in number 1. So I know that was a lot. Again, I do want to let you know that this is something that you don't need to worry about right now. We're happy to touch base with you on this more later. And there are more details in your welcome packet. For those of you who are EPI+ grantees, we'll talk about this more in detail because obviously you're doing fidelity assessments as part of that grant already. Okay. All right, so that was a lot of stuff. So thank you for bearing with me through all of that. Are there any questions so far about any of the stuff we've discussed before we move on to discussing your TTA plan? Feel free to unmute yourself and speak up, or feel free to post in the chat, whatever works.
I may sound completely stupid, but I don't mind sounding stupid. I would really appreciate if you're not going to email this PowerPoint or something, then I would really appreciate an acronym definitions list.
Yeah, absolutely. So we do have, I'm happy to send that along. We will be sending along this PowerPoint. We'll also be sending a copy of the recording of this in addition to the welcome packet, but I think that's a wonderful idea because there are a lot of acronyms in coordinated specialty care. So we're happy to send that along to you. That's a great question.
Well, the first one is just CSC. If you could, what is that? What is the model?
Yeah, absolutely. So, again, CSC is a coordinated specialty care model. And yeah, unfortunately, we don't have, I wish that we had time to just do it. Yeah.
You need to go, want me to give a brief explanation?
Sure.
That would be great. Thank you.
No problem. Yeah, because, we've had the opportunity to review everyone's applications. And so we are sort of familiar with which counties have a sense of what CSC is, may have programs, or may be partnering with other programs to develop something for their community. And then which counties are sort of newer. So this is a newer model, And the idea of it is to provide a coordinated team of services to individuals who have had the recent onset of psychotic symptoms. So those psychotic symptoms could be part of an affective illness like depression or bipolar disorder, or it could be non-affective like schizophrenia. It really depends on how your county wants to define that. And that's something we can talk about in consultation. But the idea is that you have a team that is co-located, and again, we can talk about what that means, so that everybody has a chance to meet together, including the prescriber, a clinician. We really encourage the inclusion of peers and family partners so that you can provide family education and support. There's a supported education and employment person, and then case manage it. And this model, which is the NIH model, is a little bit bare bones. So we kind of consider it to be the minimum. We will certainly show you other ways in which you can build it out. And Jess mentioned that one of the ways that will support you is thinking about what your community needs. So for example, there's no substance use on this, which for some folks, for some communities, that's a really important part of what they're struggling with. So how can we bring that into your model to support them in their recovery journey? All of this is supposed to be very client and family centered, focusing on their goals, how we support them in their recovery journey. So, so again, it's a team-based model where everyone on the team has the opportunity to meet together regularly and discuss the clients that they're serving to coordinate care. So that's why it's coordinated specialty care model. Does that help?
Yes, I'm curious because this fits very nicely into the CAL AIM initiatives, but it's also very similar to wraparound, is it not?
It's similar to wraparound, although in that a team serves the client and family. I think there's some wraparound models where psychotherapy isn't always as core, and this does have a core psychotherapy component to it. I think one of the, I like to call it comprehensive outpatient. Some people like to say this is what good mental health care should look like. But I think the idea, thank you, Kimberly. Kimberly's like, yes, I agree. You know, I think the idea is that folks who are struggling with serious mental illnesses like psychosis need more than meds and case management, which historically has really been the model. And it's also been a very adult-focused model, not a family-focused model. About 95% of these folks live with family or other important support persons. So the goal of this is to bring them in, build their natural supports. And also a really important part of this is not just symptom management. It's recovery. It's getting people back to community, work, school, all of the things that they want for their life. So it's a very, again, client and family centered, recovery driven model. So you're right. It feels like wrap, but I would say it doesn't have to be that high intensity. Not all folks are going to need a touch every day. Some folks are going to get stable real quick and want to like meet once a month or every other week, but the team is there to catch them if things don't go as well. And so this will, as Jess said, we'll send you a video that'll describe this in more detail. But for those of you who are newer to the model, please don't hesitate to ask questions, because one of the exciting things that we're really thinking about here in California, particularly for our low population density or our rural counties, is what other innovative ways could we build this model in your community so that you're providing all the services, but maybe you're providing it as part of an integrated primary care program. That's totally possible. So we want to have flexibility where we can have flexibility and make sure that the core components are really being delivered in a way that ensures the best outcomes. So that's where we'll partner with you in the consultation piece. Great question.
Thank you so much. That was wonderful.
Oh, you're welcome. You're welcome.
Awesome. Yeah, no stupid questions at all. That's the point of this meeting. So we're more than happy to answer your questions. And I do appreciate your patience. Unfortunately, we don't have a lot of time to dive into CSE, but it is really exciting. And we're very excited to teach you about the CSE model. All right, I did also see a question about fidelity assessments, and I answered briefly in the chat, but I want to make sure that we touch base on it a little bit more. So there was just a question about how fidelity was being measured. So we'll be using the FEPS-FS to determine, it's a fidelity scale developed by Dr. Dawn Addington. And these assessments will be conducted using administrative data, patient numbers and staffing, health record data, components common to all patients, interviews with clinical staff and clinical services, and staff training provided. So that's a little bit of an overview, again, of what these fidelity assessments will involve. Again, I don't want, I'm happy to answer your questions, but I don't want you to stress about this too much right now, because we're happy to provide more detail when we get closer to the dates of these assessments. But I hope that's helpful. I can't remember who originally asked this question. This is AG. I don't know if is that helpful? Feel free to give me a thumbs up in the chat, or feel free to shout at me if you need more information. All right, any other questions or anything I haven't addressed yet? Awesome, thanks AG. Okay, I'm gonna go ahead and move on, but if you think of any questions, feel free to unmute and mention in the chat, or unmute or mention in the chat, and we will have time for more questions soon. All right, so we're gonna go ahead and talk about your TTA plan, which we've been kind of touching on a little bit here and there. So each grantee will complete 2 self-assessments as part of your grant application, and these assessments will be reviewed and updated by your TTA liaison, which is a member of our team, and then used to draft your TTA plan. So this plan will set annual goals towards improving fidelity for specific program components. Grantees will provide input on the plan goals during consultations and can change the goals as necessary in collaboration with the TTA team. And we'll be reporting plan progress to the DHCS. So let's talk a little bit more about your TTA plan and the assessments that I just mentioned. Excuse me. All right, so next steps. So program needs assessments. So as part of your grant application, you'll be required to complete the following self-assessments. And again, as I just mentioned, this is part of developing your TTA plan. So the first is going to be about your SWOT, your SWOT analysis. And we'll touch base more on that in a moment. And then an applicant program self-assessment of CSE components. And we'll talk about deadlines and how to complete these momentarily. So let's take a look at some exceptions to this. So your county does not need to complete these 2 items if your county is an EPI+ grantee. So that is San Francisco, Santa Barbara, Santa Clara, Nevada, I believe are all the EPI+ grantees on this call, because you've already done this and we've already been working towards your TTA plan, right? So no need to complete these if you're an EPI+ grantee. You also do not need to complete these forms if your county does not currently have any sort of early psychosis program. Please feel free to take notes or fill out these forms according to what you think your program will be able to provide based on your current resources once it is formed. And we will discuss more at our first individual meetings with your team. So just again, to reiterate, you do not need to complete the 2 forms that we're about to mention if your county is an EPI+ grantee or if your county does not currently have any sort of early psychosis program. All right. Okay, so we're going to talk first about the SWOT analysis, which is one of the items we just mentioned. So a SWOT analysis is a self-evaluation that identifies strengths, weaknesses, opportunities, and threats, that is SWOT, of your early psychosis program. So we're going to look at a blank SWOT analysis form. So here's just an example of what the form looks like for reference. We have quadrants with strengths, weaknesses, opportunities, and threats. And we also have some ideas here to some sort of prompts to give you a feel for what you can write according to what's applicable to your program. And we're going to go ahead and give an example of this. So we're going to look at an example of a fictional county's SWOT analysis. All right, so example is Utopia County. Utopia County is a medium-sized county in California with newly acquired funding to develop a coordinated specialty care program. The county is excited to be moving forward with this following 2 years of research and planning for early psychosis care. A local lead has taken the initiative to visit other counties and to understand more about implementation of early psychosis care in the USA. The county is geographically diverse with urban and rural populations. The urban center in the county is well-resourced and generates a lot of income through tourism. However, it is a high-cost living area with many residences owned as second homes and a seasonal migrant working community. The rural areas are under-resourced with limited public transportation and limited access to high-speed internet. Rural infrastructure is not well established. Although the county has a good connection with the Latinx community, there is less penetration into the Asian and Pacific Islander and African American communities in the county, resulting in underrepresentation in the mental health system. The county mental health system is beginning to develop relationships with local tribal communities, but this is nascent. The county has struggled recently through the wildfire season, which has been disruptive to the local economy, staff, and community wellness. A recent system-wide DBT training resulted in training fatigue and burnout amongst staff. All right, so now we're going to take a look at what this county SWOT analysis would look like. Okay, so first here we have their strengths according to this little description that we just gave. So strengths include highly motivated staff, excited to provide early psychosis care, right? They've taken a lot of initiative already. Local champions of early psychosis care, good connection with Latinx community, good connection to resources in urban areas, good penetration of bilingual workforce, and active recruitment for mental health workforce. So those would be some of their strengths. Weaknesses, so challenges in coordination between adult and child system of care. Previous attempt at system change was unsuccessful. Limited penetration into Asian and Pacific Islander and African American communities. Rural areas are under-resourced. Incoming mental health workforce will be recently out of school and predominantly unlicensed. So those are some of the weaknesses. Opportunities, identified need within Utopia County of individuals with recent onset of psychosis. Strong grassroots agency representation with good connection to local communities interested in expanding services for recent onset psychosis. Connection with local schools and colleges throughout county, including referral pathway for students identified with mental health challenges within education system. Recent suicide reduction initiative with good uptake across the county. Initiatives to support further development of relationships with tribal communities. So these are some of the opportunities that they have not explored yet, but that could improve their program. And then threats. Migrant seasonal workers and high cost of living resulting in unstable workforce. Environmental challenges anticipated, wildfires. Pandemic resulted in high staff turnover. Recent system-wide training in DBT resulted in little uptake in practice and reports from clinicians of training burnout. In rural areas, little to no public transport and limited access to high-speed internet. So this is an example of a SWOT analysis that Utopia County was able to complete. So after this meeting, we will email you both a blank SWOT analysis for you to complete for your program and the sample SWOT analysis that we just showed on the previous slides. And the deadline to complete this will be June 30th. And then we will use this to develop your TTA plan. And again, just a reminder, EPI+ grantees, folks who don't already have an early psychosis program to speak of, you do not need to complete the SWOT analysis. All right. Any questions about the SWOT analysis before we move on to the next program needs assessment homework?
Jess, can I add something?
Yeah.
Okay, I've been getting a couple of questions from folks I know in the chat. So if you are part of, man, now I feel so bad about the acronyms. It's bad. I want to own the acronyms are bad. So Jess, could you go back to the diagram of all of the acronyms to help anchor people? So some of you are part of EpiNet or the LHCN. So that's the RO1, yeah, there we go, thank you. Okay, so you are part of those. So I'm not trying to call anybody out, but I'm gonna call out Solano County. So Solano County is part of the LHCN already. they are part of EpiNet as our partner. So that means they've already done a fidelity assessment. And so I got a question being like, do we need to do this? And I was like, yes, actually you do. Should take you very little time. If you've already had a fidelity assessment as part of the LHCN or EpiNet, you can use that pretty quickly to do the self-assessment that Jess is going to talk about. Please do the SWOT, because remember, this is about training. And we really want to make sure we get your perspective on your training needs. So that's where it's going to be really important. It shouldn't take you very long. I also got questions if you're partnering with an existing program. So like maybe you're a new prep site. And so you're partnering with an existing early psychosis program. Please meet with that program and discuss how you're going to provide the services that are outlined in the needs assessment, and then do the SWOT with them. So if you're partnering with me for an EDAPT is providing your services, then we will do the SWOT together, because there will be strengths, weaknesses, opportunities, and threats that we will want to think about. So we got a lot of folks at different stages here. And so I just want to make sure everybody knows where they stand before they launch into spending time on these documents that we're sending you. If you have questions, please ask. If you're unsure of kind of what you should be doing based on where your program is in this diagram, just ask us. So that we don't want you wasting time on things that may not be helpful in the end.
Thank you so much, Tara. All right, let me go back. Are there any questions about the SWOT analysis? As I flip through.
Jess, how long should the SWOT analysis take, and who should be involved?
It should be, as Tara was mentioning, if you have a program that you're working with to develop your early psychosis program, or who you've contracted with, you should be working with them. Also, I would assume that county leadership, so the leadership at your clinic, should be working to develop this and touching base with your team wherever needed. The SWOT analysis is pretty straightforward. Let me toggle back to just an overview of what it looks like. Again, it's pretty straightforward. So, it shouldn't take too long. We don't want to, this is it. This is the whole thing. So again, we don't want this to be a huge burden on you. So it's really just an overview of all of these different areas: strengths, weaknesses, opportunities, and threats. Did you have anything else you wanted to touch base on, Tara?
Yeah, no, I really appreciate you said, please talk to your county. If you're partnering, please talk to them. If you're partnering with a site or a subcontractor, please include them. Like maybe you're subcontracting for your peers or your supported education or your med management. Bring them into the conversation. This is a nice opportunity for you to start thinking about that collaborative team that you're building, and the strengths you bring and the challenges you may face. I also really want to encourage folks, if you have peers on your team, in your agency, please include them in this conversation. They will see things that you might miss as a administrator or a clinical team lead, things like that. So I really want to strongly encourage you to bring your peers in. I would say an hour is the time you should spend on this. It will be just the beginning for a conversation. So I really don't want teams to feel like they have to spend an inordinate amount of time. This is to get you thinking, and that's all. So please don't spend more than an hour on it.
Thank you. All right, are there any questions about SWOT analysis? Any additional questions? If anyone wants to unmute or raise their hand or put a question in the chat. All right, I see a question in the chat here. We in Merced have just completed an RFP process to find a provider for these services. We plan on having a provider next year, but not at this time. Do we need to complete this? Tara, I'm interested to hear your thoughts, but I would say probably not if you don't have a provider for these services yet.
You know what? I think what I would say is similar to what Jess is saying, which is let's have a conversation with your Merced team. Because I think where we could be helpful is helping you think about the provider that might be the right one for selecting for the RFP. So we might want to look at that needs assessment, think about some of those things and be like, what is it that you're looking for? So it might be good for us to have a meeting with y'all sooner rather than later, just to orient you to some of the things you might want to be thinking about. So take a look at the measures, think about the measures, bring up questions for your county team, and let's meet and talk about it. Does that help, Sharon? Great.
Awesome. All right, and I also think that our next needs assessment that we'll touch base on might also help you conceptualize, you know, some of the services and components of CSC that you might already be providing in Merced. Maybe there's some overlap. Any other questions about the SWOT analysis before we move on? All right, feel free to stop me if you think of anything. Tara, I'm going to mute you.
Sorry.
No, it's okay. All right, let's move on. And again, feel free to stop me if you think of anything. Okay, so let's talk about our next needs assessment. So again, these are the two needs assessments, SWOT analysis, and then the next one we're going to discuss is the applicant program self-assessment of CSE components. All right, so let's talk about this one. So because the goal of the TTA is fidelity to the CSC model, the coordinated specialty care model, your program self-assessment of CSC components is a self-assessment that will evaluate your early psychosis program's performance. It says 17, that's a total lie. It's 22, I believe, on 22 fidelity components on a scale of 1 to 5, 1 being the lowest and 5 being the highest. So we're going to look at an example of this form in a moment. All right, so this is what the form looks like. I'm just showing you sort of the top of the form. This is 2 out of 22 questions for CSC components here. So we have directions here on this form. You'll be asked to rate your early psychosis intervention program on 22 components of CSC. Please rate each item on a 1 to 5 scale specific to that item, with ratings of 4 and 5 indicating satisfactory fidelity. Please note that where these items were adapted from, just in case you're wondering where these came from. All right, so for instance, number 1, this CSC component is timely contact within weeks of referrals. So we have 1, 2, 3, 4, 5. So you're going to check the box that best suits your county. So for instance, 1 is target met for in-person appointment for 0 to 19% of patients. And then on the opposite end of the spectrum, we have target met in-person appointment for 80% or more of patients. So wherever your county lies in this area, or in this sort of on this spectrum, you're going to check that box. And then our next question, comprehensive clinical assessment using semi-structured evidence-based approaches. Again, we have sort of over here at one end of the spectrum, and then we have over here. So all assessment items found in 0 to 19% of patients, all assessment items found in 80+% of patients. All right, so this is an example. And again, we're going to send you a blank copy of this for you to complete. So after this, no, I just said that. After this meeting, we'll email you a blank applicant program self-assessment form to complete by June 30th. And we will use this in addition to your SWOT analysis to develop your TTA plan. Are there any questions, or I see a question in the chat, or Tara, anything that you wanted to add?
No, again, you guys are gonna ballpark. Please do not like try to pull up data and look at data. Like, don't do that. Just be like, I feel like about half of our folks get this. I feel like about, you know, and talk to your team and see if folks agree. Yeah, that sounds about right. This is just to get a general sense of how things are going. Okay. Again, do not spend a lot of time on this. So I want to appreciate Jude Lung's question in the chat about the FEPS. So we are trying to think about a variety of things. I think Zoom is actually the easiest of them for the FEPS and how it applies to California programs. For those of you who are not familiar with the FEPS, so that's what this is based on, this self-assessment. It's an internationally recognized fidelity scale developed in Canada, where they have a national early psychosis implementation approach and a population health approach to mental health care. So their system is just very different than ours. So in that, we've tried to make adjustments for the ways our health systems work, our funding systems work, all different sorts of pieces. And so when we do the fidelity assessment, we will rate the items appropriately, according to Dr. Addington, who's a consultant. And we then give feedback that really takes that larger contextual situation into account. So I think our scores are just a little different here in California, and we really try to help all of our sites understand what that means, as well as sort of thinking about that on a national scale. We don't have a US-based approach to fidelity. There's a number of different fidelity scales. And so we are part of a larger national conversation that is attempting to address this. So for us, we use the FEPS as a ballpark to make sure the components, the approach to coordinated specialty care is aligning with expectations. But please don't take it as like a test that you're being graded on and you have to pass. It's just a structure that we're using to help guide our training and TA. Jude, does that answer your question? Okay, great.
Awesome. Any other questions about the applicant program needs self-assessment before we start to just sort of transition over to general questions? And again, feel free to unmute or put your question in the chat. Stunned silence because we've done an awesome job. I'm assuming.
Or people are overwhelmed and confused.
that is also completely.
Could be either. It really could be either.
I see.
Go ahead and ask a question. This is Tracy from Solano County. How is any of this going? Is any of this going to be leveraged or utilized or brought into the Early Psychosis Learning Healthcare Network?
Oh, Tracy, I love you.
Sarah?
I mean,
like how do we? I don't know. I feel like we're all doing all this important work, and how does it eventually, or can it get woven together in some form or fashion?
Yeah, I think that's our goal.
To answer today.
Yeah, no, I think that's a fantastic goal. And Tracy, I want to appreciate your long-standing advocacy. There are some folks on this call who've been like working at a state level for many, many years with me. And Tracy, you're one of those people. So I think, maybe to give some folks a little bit of history here, is there were a set of very innovative counties and programs. LA County, which is represented here, Solano County, which is represented here, Napa County, Orange County, and San Diego County. San Diego's here as well. And then we have some other programs who have been part of this conversation for a while. I know Adriana's here from PrEP. I know Jude is here from Contra Costa. There's a number of folks who've really been trying to move California toward a more comprehensive, coordinated approach to early psychosis care. And so the really innovative counties and programs help to develop the Learning Healthcare Network and put money behind this idea of how do we collect harmonized data to show this state the impact of what we are doing. the PSC 35 and the cans just ain't catching it. We are really having a big impact, and we want to demonstrate that so we can have more secure funding. I run programs in Sacramento County. I know what it's like to have funding change or come or go. It's hard. And I have an incredibly supportive county, but it's hard to keep this work going. And then we have some communities where the money isn't enough to stand up a program or maintain a program. So then does it just mean folks with psychosis in those communities don't get access? That doesn't seem very fair. So what we tried to do with the LHCN is bring these counties together so that we could co-create the outcomes data collection system that the counties, the programs, the clients, the families wanted. It was driven and decided by them. And from there, we were able to say, hey, we're going to learn a lot of places where we need some help and some training and where we're not meeting needs. What are we going to do about that? And that's where the OAC stepped in and said, with AB 1315 funding, yes, we want to support more statewide training and technical assistance, because what was happening across the state differed county by county. And it wasn't really aligning to the evidence-based practice. So that's where we started the TTA. And we were able to bring in programs and counties through EPI+ and have been able to, through these little assessments that Jess just talked about, understand what their training needs were and then build a system to support them. So I think that's what got us here today. DHCS said, hey, we're funding these programs. We want to get them the same training. And so they came to us and worked with us to provide more training and technical assistance to our DHCS funding programs, which is fantastic. So excited to see DHCS coming to the table and becoming invested in this statewide approach. So Tracy, let me come back to your question. I am hopeful that this represents a shift in how California wants to support individuals who have been underserved in our community mental health system. I also want to see our programs, our counties, get the support they need to provide the best care that they can. Everybody's just been trying to make it work as best they can. Sometimes they've been lucky enough to partner with an experienced program or a university. They've had the money to partner and get that training, but that's not available to everybody. And so I'm really hoping that this helps to increase equity and access to high quality training. And then I hope you all see the value of that and advocate for it to continue. I think we have to recognize that the way California is built is the counties have a lot of power. And so that is why, as Jess is saying, we want your feedback. We want to understand what your needs are. We want to be here as a helpful support to you so that you see value in what we're providing and want it to continue. I think if DHCS hears this is great and this is what we want and this is taking us in the direction that we need, they will continue to support it. Now that's the training and TA piece, right? That's not the data piece. And this is why, we could have not told any of y'all about the LHCN, right? But we think that's really important because that's what's going to drive us towards investment on the other side. We have to be able to show the places where we're succeeding. We're changing hospitalization. We're changing school completion, job attainment, all of those amazing things that we want for our clients, right? To show, yeah, this is really working. We also need to show the places where we need more money. For example, we were talking to one of our programs that's in the EpiNet. They are here as well. And we were talking about data, and they had been collecting data, and they were like, man, so many of our folks need a higher level of care, and there isn't one in our community. There isn't a TAY, Transition Age Youth, full service partnership. So our folks keep falling through the cracks. And then I was like, great, how do we use the data you're collecting to demonstrate that to your county? And they were like, oh my gosh, we have that data. And I was like, yes, it's right here. So those are the places where the data, I think, can also help us advocate on a state level for the things our programs need. Yes, we need peers. We need more peers. We need family partners. These are the ways in which they're impactful. We need more prescribers. You know, whatever it is that we think we need, we'll have data to back that up. You know, I think these are really important pieces. And this is why for us, the training part and the data part go together. And so we're hoping that in bringing all of these complicated acronym-based things together, it will amplify not only the impact of our work, but the needs and the areas for continued investment so that we can keep doing and then do more. There's lots of folks in California that don't have any access to these services. And that is devastating for them, their communities, their families, and that needs to really change. Tracy, did I address your question? Do you want to say more? I mean, you've been doing this for a while. I think, you know, the other side's hearing from you. I know you're not feeling well today, so I'm sorry to ask you to talk, but
That's okay.
I just want to empower you. If you want to share more of your perspective as a county leader, I think that would be important to hear here.
Yeah, no, I tend to always look for opportunities to braid, connect funding, connect and break down the silos and help us start doing the work together better. And so, yeah, I just was curious how this was all going to kind of intersect, given we're involved in a couple different aspects of this already. And then, you know, we did get a Mental Health Student Services Act grant here in Solano County, and part of that project is screening for middle and high school students that are at risk of dropping out. And we reached out to our UCD partners just to give you guys plant seeds of how you can kind of weave things together. We invited them to the table to see in the screenings that we're going to do, could we embed some of the screening questions to identify early psychosis, right? And unfortunately, we haven't been able to like implement that part of the project yet, because our mobile crisis, school-based mobile crisis services are being utilized at rates no one could have ever imagined at this point. But we're adding staff in, and we hope to be able to do that. And then, you know, the school districts now are getting money directly from from DHCS through the managed care plans. And one of their interventions is screening. So it would just really be nice if we could all pull this all together. Because if there is going to be universal screenings happening in the schools, this is a really wonderful opportunity to try and identify young people very early. And so I teased Tara around the number of questions, and can we whittle that down? Because there's very many things we need to screen for, including suicidality and lots of other things. So I'm just excited about the work we're all doing. Happy to be here.
Thank you, Tracy. I really, I'm so glad you brought that up. And by the way, Mark Saville has whittled the questions down. So we're working on it. We're working on it, which we're happy to share with the rest of you as well. You know, another great place where money has been invested by some counties is in Alcove. You know, some of you have gone after the Alcove money that was part of innovation. And, you know, we have, because of Stanford, we have a partnership with the Alcove TA kind of team. And we're looking at also, as Tracy was mentioning, weaving and screening for psychosis in our Alcove sites as a way of ensuring that folks are being identified at first presentation for mental health challenges and getting to the right place quickly. So that's another funding stream. So we've got school-based mental health funding streams. We've got the Alcove innovation funding stream. There's multiple places. And so I think if your county has invested in something like that, and you're like, how could I bring these things together? That is, I would list that in the strengths of your SWOT analysis. These are the other places we've invested dollars. We would love to think about how we can bring these things together. And that will help us in our conversations with you think about those additional opportunities. Maybe it doesn't, I see it as a strength and an opportunity. So however you want to put it, which box you want to stick it in, doesn't really matter. But we would love to work with you on, as Tracy's pointing out, leveraging the investments you're making in ways that benefit more people. Other questions? As you can see, I love your challenging questions. Anything else you would like me to explain or discuss? Because if not, we're going to pivot and show you that CSC overview. You've already allocated this time, so we want to make use of it.
Can I add one more thing, Tara? I'm sorry.
Of course.
I just want to do a shout out for your team, because you just said something that I hadn't heard before around the questions being whittled down. So I want to highlight for other people that are on the call that might be intimidated by working with an academic group of folks, that this group of folks is awesome. And that they actually listen, and you come together as it's a true collaborative and partnership. So sometimes you can work in these kind of projects and it's like, I have no idea what they're talking about, back to the acronyms and the alphabet soup. But ultimately, once you start to really understand what we're doing, they listen and they take that feedback. We've also given lots of feedback around the equity lens and developing the tablet and the application, really including all communities, including our LGBTQ community. So they really do listen. So don't be intimidated. As Tara said earlier, no stupid questions. This is a way we can really actually affect change. And then I'm going to be quiet and mute myself again.
Thank you, Tracy. That is really the most lovely compliment we could have received. We want to amplify your voices, your needs, what your community wants. We want to support you all in providing the best care that you possibly can. And so we will, take anything you want to share with us. So please don't hesitate to ask or to let us know.
Thank you, everyone. And Tracy, yeah, we really appreciate you sharing all of that with us. I do want to thank you, Samantha.
Thank you, Samantha.
I do just want to sort of, before we pivot, because we are really ahead of schedule. So I think I would like to just wrap up if there are any additional questions about the self-assessment that we reviewed. I would like to just wrap that up and see if there are any more questions before we pivot to sort of general questions, and then we can go ahead and watch an overview of CSC video that we mentioned earlier.
Yeah, Jess, I'm wondering if there will be more questions after that overview. I wonder if maybe that'll help to stimulate for folks the additional large scale questions that they may have if they don't have anything right now.
Sure. Yeah, of course. Okay, so I'm hearing that there are no more questions about the needs assessments or the SWOT analysis. So, feel free to chime in the chat or unmute if there are, but otherwise I'm going to go ahead and move on to just sort of general questions about anything we've talked about, and then we can watch that video. So any more just general questions before we pivot over to that video? Okay. All right, well, feel free again to chime in. And as Tara was mentioning, I'm sure there will be additional questions after we watch this video. So let me just switch over to that for a moment. All right, you're going to hear more of Tara preaching in this video.
Hopefully not preaching, but...
I'm sorry, I didn't mean it in a bad way.
Enthusiastically sharing information.
Yes. Yes. All right. Let me just make sure that my audio is good for videos. Okay. I'm going to try to go ahead and play this and let me know if it doesn't sound good or too quiet or what's going on.
Presentation of centering us. What we know about effective treatments for early psychosis, what is the coordinated specialty care model, and how do we want to think about this within our state? So what are effective treatment options for early psychosis? So first of all, we know that a core piece of treatment is boosting protective factors. So within our treatment, we want to treat symptoms. Those can be very distressing and impairing for folks who are impacted. So that can be psychosis symptoms, but it could also be anxiety, depression, sleep, a variety of things. We want to make sure we're encouraging physical health, sleep, diet, exercise. And in this area, we also sort of talk about limiting or eliminating substances like alcohol and other drugs. We want to limit stress, but also improve our ability to cope with stress, which is the next one. But limiting stress, adapting educational, occupational, and family responsibilities to things that seem manageable for folks as they're on the process, the path towards recovery. Sometimes folks need some changes there during their recovery period so that they can kind of get their feet back on the ground. So, and then improving coping skills. These two things go hand in hand. Helping folks have skills, cognitive skills, behavioral skills, affect regulation skills to help manage their symptoms or their distress. And then also it can be really important to do problem solving and support and enhance communication within the, I'm going to do air quotes, family environment, whoever that person's primary support system is, so that that system is functioning well. We also want to increase social support, and that can come from a variety of places. It can come from the clinical team, but can also come from the community, can come from clergy, extended family, friends, pulling in people for that individual's team so that they feel like they have support. And all of this is really in the service of recovery goals. You know, we're talking about symptoms, but symptoms aren't the only thing. They're just one piece. We really want to ensure that individuals are pursuing meaningful things in their life. As Dr. Tully likes to say, building a life worth living. So work, school, relationships, romantic relationships, travel, all of the things that all of us love. These are the things that we will work with on our clients. Then, to do this, we use evidence-based treatments. So, and these tend to fall in particular categories, even though Dr. Tully and I argued about where they go and this different stuff. So they fall in general categories. So physiological can be medication management, substance use treatment, and always remembering to partner this with physical health. So making sure we're coordinating with primary care, and even so far as making sure our folks have a dentist so that their physical health is also being managed and supported. And then we have our psychosocial interventions. And so some of the evidence-based practices are things like cognitive behavioral therapy. This is something that our team has specialized skill in, between Dr. Hardy and Dr. Tully and a number of folks on our teams. This is one area where we will be able to provide training and technical assistance. Individual resiliency training is sort of CBT light. This is the version of CBT that they use in Navigate. And so this is another option for programs. So then we have cognitive remediation, doing brain games, training your brain, exercising your attention, your memory, your processing speed. You know, as we know, psychotic disorders are neurodevelopmental brain illnesses. So it's not surprising that folks also have cognitive impairments that they struggle with and that impact their daily functioning. So having treatments that address these cognitive impairments is really important to the work we do. Social skills training is another evidence-based practice that we want to consider. And there's lots of different ways in which we can integrate these skills into the services that we provide. There's group methods for doing social skills, individual methods for social skills, just really helping our clients be able to go out and build those relationships that are important to them. And then really wanting to acknowledge the power of peers. This is something in California that is incredibly important to us. And so for us in early psychosis, we see this as integral to the work we do. And so peer and family support. So when I think of peers, I think of peers, client peers, and then I also think of family peers, to speak to the lived experience of both groups. That's why we have peer family support, to have folks who can share their lived experience, provide that guidance to all of the individuals that we're working with, so that we can help them feel supported, understood, and like they're not alone, and that they have hope. So important, peers and family. Then we have our social environment. So the things that are outside the client and their family that we can also help with, so that the folks we're working with are able to be present and ready to engage in these other treatments that we're offering. Case management and linkage, linking them to other community services. I was just doing supervision with one of my clinicians, and we were talking about a transgender youth that we're serving, and how it's so important for us to partner with the Gender Health Center that they're working with, to make sure we have that tight communication to serve the whole person that we're working with. So case management can also be getting them linked to CalFresh, a phone, housing, all of those other things that are, basic needs that are important. Then we have services that are about getting back to work or school or being successful in those places. Supported education and employment, helping folks, again, either continue to be successful in the environments that they're in, or getting the supports they need at work or school so they can be successful. And then occupational therapy is an area where we also have this integrated within EPI to help folks maybe understand and remediate some of the physical or other cognitive challenges that they're having in the work or school environment. Coming back to family again, there's interventions that focus on family problem solving and communication. Multifamily group is an evidence-based practice, as is family-focused therapy. These are two wonderful evidence-based practices that, again, we will be supporting in our collaborative. And then family psychoeducation. And again, family in quotes, whomever that support network is, just helping them to understand what's happening and how they can be supportive of their loved one and how their loved one's illness may be impacting them, and then what supports they may need. So really keeping that support network strong. So we do all of these things in the context of the coordinated specialty care model. This model was developed and has been broadly implemented in the UK, Australia, Canada, Scandinavia, and is now growing in the United States. And so it includes team-based coordination of care, outreach and education, early identification, and then this combination of evidence-based treatments for psychosis that I just discussed. We really focus on the earliest stages of the illness within the first 2 to 5 years, because we know that's where the biggest impact can be made for the individual that we're working with. There's lots of different versions of CSC. There's the peer program, the navigate program, the on track program, the EDAP program, the prep program. There's a bunch of us out there, but we all sort of follow the same idea, which is we support the client, medication, variety of psychotherapies, family education support, supported education and employment, and case management. We tested this approach in the United States as part of the RAISE study, which was started in 2009. Preliminary data came out in 2016. Now, I think it's really important for us to all keep in mind that while this study was amazing, it included 34 clinics in 21 states. Huge study for the United States. It focused very specifically on individuals with schizophrenia spectrum disorders. So schizophrenia, schizoaffective disorder, schizophreniform, brief psychotic disorder, and psychosis NOS. So here in California, that's not all of what we do. Many programs in California also serve individuals with mood disorders with psychotic features, in individuals at clinical high risk for psychosis, meaning they have attenuated or subthreshold symptoms that are causing distress, but don't meet that threshold of full psychosis, or they have genetic risk for psychosis and are deteriorating. So this study is just for one piece of the folks that we serve, but it's still very important for us to know about it, because what it showed was that we can do this work in community. It doesn't have to be done at a university. We can do this work well in community sites. It also showed that folks who received Navigate treatment, as opposed to typical community care, were in treatment longer, showed a greater reduction in clinical symptoms, and greater improvement in quality of life and participation in work or school. So it worked for those things that we care about. However, treatment effects were moderated by the duration of untreated psychosis. So that period of time between someone having threshold psychotic symptoms, threshold hallucinations, delusions, disorganized thinking, and when they were accurately diagnosed and treated. This delay between these 2 points is called the duration of untreated psychosis. And for those of you who've heard me speak about this before, we know that individuals can be in treatment during this time. It just might not be for the right diagnosis. So this period in the United States is about 18 and a half months. So this 74 weeks is what they saw in this study, because they took a bunch of people and they saw that 74 weeks or 18 and a half months, that was the point. If you could catch people under 18 and a half months, they showed greater reductions in symptoms and greater improvements in quality of life than individuals who had been ill for longer than 18 and a half months. Now that's a year and a half. We really need to do a better job of finding the folks in our community and supporting them into appropriate care. 18 and a half months is too long. That's not acceptable. Would not be acceptable for cancer or diabetes. It's not acceptable for psychosis. So when we think about it across the United States, there's a lot of heterogeneity in how CSC has been implemented. The ages of our clients differ. Some focus more on the adult side, like On Track New York. My clinic goes down to 12 and up to 40. The peer program starts at 14. Navigate starts at 15. Lots of diversity. We also differ in the stage of psychosis served. So some programs serve high risk, clinical high risk, and early psychosis, such as my program at UC Davis and the peer program. But some programs only serve first episode, like Navigate and On Track New York. Again, I've mentioned the diagnosis we could include also differ. Non-affective psychosis versus affective psychosis versus substance-induced psychosis. These are all choices that different programs have made. And then the specific evidence-based practices also differ. So using individual resiliency training and Navigate versus a CBT and family focus, family education and Navigate, multifamily group. So there's lots of differences here. And so one of our goals in working in California is to try to help us come a bit more into a common idea of who we want to serve and how we want to serve those folks. So a summary of the treatment standards that we know to date: coordinated specialty care. So everybody lock in CSC. We're going to use that term a lot. CSC is appropriate and effective for individuals with schizophrenia spectrum disorders who are early in the course of treatment. That's what RAISE showed us. The data also suggests that this combination of treatments could work for clinical high risk. So, some good studies that showed this combination of individual, family, supported education, and medication reduced symptoms and functioning for clinical high risk. Similar things in this study delayed the onset of psychosis. One very important point I want to make is that prophylactic antipsychotic medications have not been supported. So we want to avoid antipsychotic use in individuals who are at clinical high risk. We want to treat the other threshold symptoms, anxiety, depression, but we want to be very careful before they reach that threshold. And then once they reach the threshold, what my doctors like to say is start low and go slow. Be very careful when you get to the threshold, because you might be surprised how little medication it takes to have those symptoms reduce. CSC has not been tested in individuals with mood disorders with psychotic features. We have evidence that CBT plus medication, that is the recommended approach for major depression with psychotic features. And then for bipolar disorder, combinations of medication, CBT, and family-focused therapy are appropriate. So really this slide is meant to highlight CSC, the approach of choice, very well substantiated for schizophrenia spectrum disorders. In California, we do lots of things. Clinical high risk, mood disorders with psychotic features too. And there's initial evidence suggesting that the CSC approach should be effective, but it hasn't been proven. So I just want all of us to sort of understand these basic pieces as we move forward. So because of the Prop 63 dollars that we had available to us in California, we developed early psychosis programs very early. And again, everybody kind of went in their own direction. It was county by county. Some counties partnered with local universities. The universities in California have been working in this space for a very long time. There's incredibly well-respected researchers at UCSD, UCLA, UC Davis. We have Camp Carter, myself, and our group, UCSF. We have really great people in California. And so some counties partnered with us to develop programs, but other counties didn't. And so we've kind of all developed in these different ways. And then after the results of RAISE came out, SAMHSA invested through the block grant dollar system. And that supported us further to enhance our programs or to grow more. So again, I'm coming back to the study that we did in 2016, this landscape analysis of early psychosis programs in the state of California, where we had 30 programs in 24 counties. 41% were active, 21% were developing, and 38% didn't have a program, again, predominantly in our rural and remote areas. And so this is where we really began to understand the diversity of California's programs. So in 2016, 3/4 of them served first episode psychosis and clinical high risk. We were doing the full spectrum of psychosis. A small proportion served FEP only. And I know some of those programs now are considering broadening to clinical high risk. And then another small proportion were only serving clinical high risk. And I know now they're considering moving towards serving FEP as well. 86% served any psychosis spectrum disorder, including schizophrenia, with 3/4 serving mood disorders with psychotic features. And then even a small group who also took mood disorders without psychosis, like PrEP's Beam Up program. So really trying to innovate in this area, trying to push this field forward. We had folks who were taking what had been learned from RAISE and trying to apply it more broadly. We also had this range of duration of psychosis from 1 year. There were some programs at the beginning who were only taking folks who've been ill for 6 months to indefinite. So not trying to focus necessarily in that early psychosis population, but sort of taking all comers. And then we differed on how long we served people. Most of us served folks for 2 years. For a small proportion, it was only a year. And then for a quarter, they went to 3 to 4 years or indefinitely. We had a variety of different treatment models. There were some of us using the peer model, some using the Felton PrEP model, EDAP, RAISE, ESA, this is out of Oregon, and then a quarter, something else, and then 7 who weren't quite sure. So as part of this paper, what we did is we used a fidelity measure called the FEPS, and we asked all of these programs, what components of care are you providing? And you can see the FEPS went up to 28. And a good number of programs were providing what was considered to be core components of coordinated specialty care. But there were a number of programs that weren't. And it wasn't that everybody was up here at the top. So we saw this as we have some room to grow. There's a lot of variability. People need support in getting to the best quality care. And through this work, we also realized a number of challenges. The CSC model is ideal, but it's really hard to shift from typical outpatient mental health to this. I know my program was implemented in Sacramento County's child mental health system. They were like, they didn't quite understand why our clients were so sick or that they needed a variety of things. We really had to work with our county to sort of help them shift in their understanding of what this team-based care looked like and how we needed them to help us figure out how to bill for the different pieces of care we were providing. This work requires a different staffing structure, different caseloads, different expertise and passion in your staff. And then, as I just mentioned, billing structures. And all of us have been struggling with this, from commercial insurance all the way to Medi-CAL and uninsured. So we've gotten a lot of questions over time about how do we do this? Like, how do we build this in our system in this state where we're all kind of doing it in isolation? And so one of the key themes that we want to communicate today is that the what needs to be the same. These core evidence-based practices need to be the same. But the how you deliver them can differ based on local needs. So for example, I'm partnering with some of our Northern California counties that are more rural and remote, and we're building a hub and spoke telehealth model. So a lot of our services are going to be delivered via telehealth, but it's the same services. Those clients are still going to get supported education and employment, access to peers and to family peers, access to groups. So again, the what stays the same, the how can change. Again, I really want to acknowledge the Oversight and Accountability Commission and DHCS for supporting us in moving this forward. They see the value and have heard our calls for help, that programs across the state need support. And so we are very grateful to them for that, and hope that this system that we're setting up and starting now is beneficial to all of you. So again, this is the framework that we have developed with your collaboration and your input. And we hope it continues to be useful moving forward. So you can see how today, we're going to be providing technical assistance, but in the future, we may provide clinical service for some sites who are having difficulty accessing particular providers. And then the learning that we're doing through the Learning Healthcare Network, a big goal of this is to identify needs, to understand what's working and what's not working in our programs. And an important piece of this work as well is understanding how clinical high risk and individuals with mood disorders with psychotic features are impacted by the work we're doing. We have a natural experiment happening here in California. We have a very diverse group of individuals being served, and we are going to systematically examine how our work is supporting meaningful change for these clients and families in the programs that are working with them. So hopefully today you can see how the history of what we've had in California and what we've tried to create through the EPI-CAL network is trying to not only provide the training and technical assistance that people have been asking for, but also answer some very important questions that our field has been wondering about for a while.
All right, folks. So hopefully that video was helpful. I'm really pleased that we had time to get to it, because obviously it's such an important piece of, conceptualizing this whole thing. So Are there any questions? Are you seeing my slides again now?
Not yet.
Not yet. Oh, because I paused. There we go. Now?
Yes.
Awesome. Okay, so are there any questions about anything, the video we just watched, or just any of what we've covered? I do see a hand up. I see Dana. Yeah, go for it, Dana.
Hi there, good morning.
Good morning.
Hi, I'm up in Humboldt County and we have an FEP program. In the what, I saw that the how, the delivery is pretty open. In the what, for the EVPs that we're using, what about things like EMDR, virtual reality platforms? Are those out of the what?
So, excellent question. Jess, I'm going to be annoying and make you go back to the circle diagram again. So I think, so EMDR is an evidence-based practice. No, not the one in the video, the one on your slides. Yeah, you'll just got to go back. Is an evidence-based practice for trauma treatment, particularly when it's combined with exposure, right? So I would say there are 40 to 50% of individuals within our populations that do have comorbid trauma. And for individuals who have more established psychosis, meaning they've been ill for a few years and are stable and have a comorbid diagnosis of PTSD, there is evidence suggesting that treatments like EMDR are effective at reducing trauma symptoms as well as psychotic symptoms. That is not first episode psychosis. There have been very few studies of treating trauma in first episode psychosis. In our learning collaborative a few months ago, myself and Dr. Kristen LaCrosse, we actually presented on treating trauma in first episode psychosis. It's a 2-part series. And Jess, do we record that? And are we going to be making that available as one of our recorded trainings?
What was the treatment? Yeah, they're already available on Canvas.
Okay, so we will be making that available for you all. So I think for programs, so this core that we're showing you right here, and in that psychotherapy component, that CBT for psychosis or individual resiliency training is really foundational. We want to make sure our folks are getting that foundation of psychoeducation, coping skills, and ability to manage their psychosis in a way that is focused and evidence-based. And so really the evidence is going to, for psychosis symptoms, points us to cognitive behavioral therapy and individual resiliency training, which is part of Navigate. From there, I would say once your team feels good about that, we could support you in building on more trauma-focused approaches. So that was the EMDR part of your question. The virtual reality piece that you're speaking about, I think, is an interesting idea if what you're wanting to do is think about exposure, right? Exposure to maybe unusual perceptual experiences, using it, encouraging people to use their coping skills as part of that.
Right, leaving the house. Yep.
Yep, exactly. I think, and I would want to call in Dr. Tully or Dr. Shapiro, who I also, maybe he had to drop off. I would call them in as thinking about what does the evidence show for those approaches to exposure, because I think we would just want to make sure before we recommended anything like virtual reality that we had reviewed what that environment was like, and we were clear on how we were going to implement it. Because for some folks who maybe hadn't worked on enough skills, that could be incredibly distressing, right? It's exposure too soon. So those are all of the things in a CBT framework we would want to think about. And Tully, I'll give you a second to chime in. So I hope, Dana, what I'm saying to you is, oh, great, thank you. We love technology. We'll talk to you about technology all the time. But I would want to encourage the Humboldt program to focus on how they want to build in those foundational skills first before we go to these, what I would consider higher order types of experiences that may be appropriate for specific clients that are coming to you. Does that help, Dana?
It does. Thank you. Yeah. So it's and I get it. And I think that's what we're doing, right? We've had CBT training, and we're finding like some young people love it and some want nothing to do with CBT. They find it annoying. They don't like the homework. And so trying to find these different kind of innovative, and I would say maybe popular ways of bringing young people in the door so that they'll even engage with us. And things like EMDR and VR are very popular. They're on TikTok, just trying to meet people where they're at.
I love it. Tully, I know I want to let you have a second because I know you're going to want to speak to that.
Yeah, Dana, thank you so much for bringing this in. This is a topic that's really close to my heart. Is how, like you say, how do we meet people where they're at, and how do we leverage really amazing technology tools to enhance the work that we're doing? And I think you're thinking about it in exactly the way that we do. So that's really exciting to hear. And as you know, and many people on the call know, whenever we're thinking about implementing technology, whatever that might look like, whether it's doing outreach through TikTok, which is actually something that the learning management team is talking about doing a training on, which we're really excited about, or implementing some piece of technology in your treatment program to enhance the work that you're already doing, there are things that you have to consider. And I think the three most important ones that I would say is, one, do you have access to that technology? Does your clinic know how to access it? Can they access it? Are there firewall issues about accessing TikTok within your clinic? Do your clients have access to it? So, this idea of using smartphone applications to support treatment requires your clients to have a smartphone that's compatible with that application. For many of our folks, particularly those who are in the Medi-Cal area, receiving medical services, they might not have smartphones, or they might not have smartphones that are compatible. So then how do we support them in accessing those kinds of instruments? And then for things like VR, it's very exciting. There's some really cool trials happening right now, but they require specialized equipment that is expensive. So is it the kid that has to buy the equipment, or is it the clinic that buys them? So these are barriers that I think as a field, we're trying to figure out right now. I am eternally optimistic that we will figure it out. And if there are programs on this call who are A, interested in doing this, B, maybe have already solved this problem, then this is exactly what this learning collaborative is for. How did you figure this out? How did you handle accessing this technology? How did you make it more accessible for your clients in terms of equipment, language, safety, right? If you're going to have youth accessing TikTok to get information, how are we making sure that they're in the safest place on the internet, right? So these are questions that we have to think about as a field, that I think this is a place to do before we even get into the idea of what is an evidence-based approach using these tools, although there are lots of cool evidence-based approaches happening. So as you can tell, I'm like immediately very excited by this question, and I could probably keep talking about this for the next 30 minutes. So I'm just going to pause and just say, we'll be talking about it. We want to think about it this way. And I want to hear about everyone's ideas on how they're already doing it.
Mm-hmm. That's awesome. That's great to hear. I'm glad that it's on the radar and being.
Oh, very much so. I would like to build my career doing this stuff. I mean, it's where we should be going. It's you're absolutely right. Yeah.
And the youth are kind of already there, so it's like I feel like trying to catch up to them right now.
Yeah, so. Way ahead of us. Way ahead of us. Yeah.
Well, thank you. I appreciate the responses.
Are there any other questions just in general about anything? Sorry, I'm just toggling through.
One thought I just, Dana sort of just sparked like this idea, in my head. Some of you in your communities may be thinking about targeting particular populations, like groups of folks that maybe you felt the needs are really strong in your community and you haven't quite gotten there yet, or you recognize that they're just a really key part of your community and you're curious about how to engage. And so this could be, I'm going to just throw out a bunch of things, right? It could be the Vietnamese community, or it could be, you know, the Native American Indigenous community, or the LGBTQ plus community. Like, you may also be thinking about how we could be innovating, as Dana sort of suggesting. How do we shift what we're doing to meet these folks where they're at, and engage them in a way that maybe we haven't been so successful at, or what we're trying isn't working, right? I just want to say we are all for that too. Please bring to us the ideas you have, or the questions and the struggles, and say, how could we do better by this? I can say, you know, in our work that we've been doing already with the Learning Healthcare Network and the TTA, we've really been trying to focus on our non-English speaking communities broadly. Like the LHCN, I think, I can't even, Valerie, how many threshold languages are we working for?
13.
13 threshold languages.
Uh-huh.
So, you know, we really want to acknowledge that lots of us in our programs are trying to address these challenges. And so that is totally open for discussion, for support, for creativity. You know, and if you found a successful way, we would love to hear about it. Again, this is what the Learning Healthcare part is about. Some of you may have made fantastic inroads in these areas, and please share that. You can put that in your SWOT, into the strengths. We've done a great job engaging our Vietnamese community, and we would love to share that. We would love for you to share that so that we can learn from you as well. So not only are we trying to be here to provide, we also want to support you all in sharing with each other how you've been able to support your unique communities, and bring these services to them.
All right, I see a question in the chat. All of this has been super helpful and exciting. Glad to hear it, Raquel. Will we be bringing the SWOT that we complete for our programs to the next meeting? Yes, yeah, we will be going over your SWOT and the other needs assessment that we discussed that has a long name that I can't remember right now. And we'll be reviewing those to start talking about your TTA plan. So,
Jess, when are you going to start reaching out to programs to schedule those meetings?
Sometime in July. Yeah.
Okay, just wanted folks to know. So you have, right, our deadline is the end of the month, June 30th, right? Is that correct, Jess? Yes. So if you guys want to get those into us by the end of the month, we'll just be like saying, like, you did it, yay. And then we'll have those, and you can continue to revise them or change them. It's just, we ask that you send us something, a good working draft by the end of the month, so that we can let DHCS know they have completed their preliminary analysis. That's part of our, one of our deliverables. And then Jess will be reaching out to you in July to get those things set up. So, you know, we've got time, you've got time. We wanted to give you plenty of time to do that. If there are any challenges or barriers to completing it in that time, I want to acknowledge we're still in the time of COVID. We are still heading into fire season. If you have any challenges or barriers, please just let us know, okay? We don't want, I know sometimes when it's related to funding, folks get nervous. They're like, will we lose our funding if we don't? No. That's not our job. Our job is to help you feel supported. So if you need more time, if you're experiencing challenges, please just ask. Let us know and we're here to help.
Thank you, Tara. Let's see, I'm seeing that we're at 10:56, so I want to make sure we have time for more questions if folks would like to ask any questions before we just review what the next steps are. So any more questions about anything? And again, you know, you're more than welcome to reach out to us if a question pops into your mind after this training or anything comes up when you're reviewing the materials that we send out. We're happy to help however we can. All right. Well, again, feel free to chime in if you do have any questions. Otherwise, I'm just going to go to our next steps. So what happens next after this meeting, as we've mentioned, we will email you the SWOT analysis blank form for you to complete and the sample just for you to reference. And again, we ask you to please complete these and email them to me. That's my email address right there by June 30th. And I will, yes, Tara's saying in the chat, please email me if you have any questions. You will all see me in your inbox within the next hour or so. So you can just go ahead and reply to that email if you would want, if you want. And again, yes, the slides will be sent out as well. The slides and a recording of this training will be sent out in addition to some other items. So SWOT analysis, applicant program self-assessment. Again, same thing here. Please complete this and send it to me by the 30th. We'll send you a link to our overview of the coordinated specialty care model video. That's the video that we just watched. Didn't think that we would have time to do that, but thankfully we did. But if you want to rewatch it, you're more than welcome to. So we'll be sending out the link to that. We'll also send out our welcome packet, which we've referred to throughout the course of this meeting, right? The welcome packet has a lot of detailed information about our program that was not covered during this meeting. So I want to encourage you to review that. And then a copy of these slides we will send out as well so that you're able to refer to them. And then there was also a request to for a list of some acronyms, which we do have, so I'm happy to send that out as well. And then looks like we'll also send out the original white paper on CSC, and we're happy to do that as well for, if you would like to refer to that. All right, so those are the next steps. Any last questions before we close out for the day?
No, just thank you guys. Thank you for all the work you do. It's not easy corralling a bunch of counties. It's like feral cats.
No problem. We're happy to support and very glad for this. So thank you all so much. Again, if you have any questions, you're more than welcome to reach out. And just thank you from all of us on our team. We really appreciate all of you. All right. Thank you all so much. Have a great rest of your day and keep an eye out in your email for a bunch of stuff from me. Thank you all so much.